Hi, I'm Josh Yamamoto from the Foxall Foundation, and welcome to Real Doctors, Real Medicine. I want to start off with a series on preventing vascular dementia. Now, first of all, who am I and who's the Foxall Foundation? I'm a cardiologist. I'm in private practice. I'm a Washington, D.C. native, and I still practice medicine here. I actually didn't start off planning to be a doctor. I went to Princeton in the 1980s and graduated with a degree in physics, and I mention that mostly because I went to college with a typewriter. The 1980s were a time where we emphasized knowledge, but as a physics major, we always tried to understand how to solve a problem, to understand why things work. We couldn't just look something up on the internet. We really had to strive for a deeper understanding. When I went to medical school, I went to medical school in New Hampshire at Dartmouth. One of the deans singled me out and tried to warn all of the classmates. And he said, "Oh, you studied physics. You didn't learn anything." But he actually meant it as a compliment. And what he was saying is that the practice of medicine isn't just a bunch of facts. And today we'd say medicine isn't just a bunch of algorithms. It's about understanding. It's about solving a problem. From there, I went on to study medicine at Johns Hopkins. And then the Navy reminded me of this thing I had signed for them, and I spent 8 years on active duty, including a tour in Kuwait and Iraq, at which point my wife said, "When you come home, you will be going into private practice." So I've been in private practice in Washington since. The Foxall Foundation was started in the early 2010s, and originally it was to help create a pilot program when the Johns Hopkins medical system bought up our local hospitals in Washington. We thought this was a great thing and a wonderful opportunity. Johns Hopkins, as you may know, is an amazing academic institution that has some of the best and brightest coming up with new research and ideas on how to do things. And guys like me went into private practice, really seeing patients and working. And we noticed that there were academic ideas and great programs, but they didn't always make it into the community. They didn't always make it into the hands of the doctors practicing real medicine, seeing patients day in and day out. And one of the first programs that we noticed was phenomenal at Hopkins was a dementia program. So I did mention I'm a cardiologist. I'm a cardiovascular specialist. Why on earth would I know anything about dementia? And in fact, I don't. I'm not a brain doctor. I'm not a neuroscientist. But in our town, most or a big part of the problem of dementia isn't Alzheimer's, it's vascular dementia. What's the difference? Alzheimer's is a very specific type of dementia. And in the future, we'll go into that. But there's also a component of what we call senile or age-related vascular dementia for all of us. Fundamentally, if you do not get enough blood flow to the brain's not going to work well. That is a cardiovascular issue. It goes by many names, and there are many ways to understand it, and we do sometimes parse it down into too fine detail. But fundamentally, you need to have good blood flow to the brain. If we don't have good blood flow to any organ in the body, that organ's not going to work right. So certainly the brain matters. It doesn't mean you can't have Alzheimer's. It doesn't mean you can't have Lewy body dementia or frontotemporal dementia. There are many types of dementia. But in real medicine, what real doctors have to deal with is what are the things we can help with? And we can certainly help with maintaining good blood flow to the brain, which always matters. One of the easier ways to think about this or to start is to say, my goodness, I don't want to have a stroke. What's a stroke? A stroke is a blood clot in the head. We think of them as very tragic things, but they're not random. In the early days of the foundation, a patient of mine, wonderful fellow named Bill Lilly, had seen an article in the Washington Post about the latest treatment for someone having a stroke, a rescue therapy, if you will. And everyone was really excited about this. How do we rescue somebody who's having a blood clot in their head? And he called me up and he said, "Hey, Josh, what's the best way to treat a stroke?" And I said, "Bill, that's the wrong question. The best way to treat a stroke is to prevent it." And he was kind of dumbfounded, gobsmacked, as my South African friend would say. He said, "You can prevent a stroke?" And I answered him, "Yes, Bill, you can prevent a stroke." He looked at me and said, "You got to write that down." So about 2018, 2019, we put together a series and turned it into a book through the Foxhound Foundation called You Can Prevent a Stroke. You're free to get it on Amazon, or you can just watch these conversations because that's what really the book is about. An alternative title to that original story was not You Can Prevent a Stroke, but it was The Baby Boomer's Guide to the Prevention of Vascular Dementia. And our publisher's like, yeah, that's way too long and complicated. Let's just stick with the things as simple as possible. This is how a cardiovascular doctor got involved in what started off as a dementia program. Not for the treatment of dementia, at least not at first, but for the prevention of the age-inevitable vascular brain injury. Inevitable? All right, what do I mean by inevitable? Something that became real clear to those of us in private practice is that we tend to view everything as a bag of diseases. We get older and we have to label it all as a disease. This is a disease, that is a disease. We give things a label, we call it a disease, and then by golly, we have to fix it. But you know what? It's not exactly a disease. And sometimes our thinking about things as a disease is a little bit absurd. If you're walking along and feel fine, you may not think you have any issues, and then you could have a heart attack. The day before, nobody would say you had a disease, but suddenly today you do. All of that happened in a day. A heart attack is when we have plaque building up in an artery, a blood vessel, feeding the heart in this case, and then it clots off. Well, that plaque didn't just appear that day. That plaque has been growing for years or maybe decades. So today, having had a heart attack, we say you have coronary artery disease. Yesterday you didn't? No, that's absurd. You've been growing that plaque for a long time. And we could have prevented it. And it's not just diet and exercise. That's an important thing. There are many aspects of how we age that are beyond just, oh, eat right, exercise as if we know how to eat and we all know to exercise. But what can we do to actually manage a process, a natural process of aging? So this is where we begin to change the model of how we think about our own health. Instead of having everything based on a symptom or a disease label, we think of a process or the many processes as things change over time. We have some absolutely inevitable processes that affect us over time. So this is a very important concept. We can't change the fact that time passes. I can't avoid next Tuesday. It's coming. Worse, next Monday. Time is going to pass and things are going to change, but we have a wonderful and amazing understanding of the processes that will affect us as we go through time. And we have the option, really the responsibility, to manage those processes. And to think that, oh, if I do everything right, I'll never age. Certainly we can make good decisions to help us manage the processes, but it's really important that we just acknowledge none of us are exempt from time, nor are we exempt from our genetics. And so we have a pre-programmed genetic code of how we're going to manage aging, and it's up to us to manage it well. Okay, getting back to the brain. Vascular dementia. Dementia, in general, we could say is impaired cognitive function. We don't think right. How do we think? You know what? We don't know. I like being a cardiologist. I was a physics major, as I mentioned. I'm a very mechanical guy. The heart is a pump. It is a pump, it's a pipe, there's an electrical control system. It is very methodically mechanical. Every part of your circulation we can measure. The brain, I can't tell you how we think. I know that if we beat up parts of it, it won't work right and we won't think right. But dementia is impaired cognitive function. So what is vascular dementia? Broadly speaking, again, I am a cardiovascular doctor, not a neuroscientist. But if you have inadequate, interrupted, or impaired blood flow to your brain is going to suffer. Can I tell you exactly how it's going to suffer? Well, if you have a big blood clot in your head, you kill off that part of the brain. And we've learned a lot about damage to different parts of the brain, and maybe you can't see, maybe you can't speak, maybe you can't move your arm or your leg. So we can understand the deficits, what we lose with a stroke. But the brain as a whole needs to have good blood flow. Senile, which means age-related, it's not meant to be an insult. Vascular dementia is the loss, perhaps gradually or abruptly, of cognitive thinking function because of inadequate, impaired, or interrupted blood flow to the brain. Okay, so now we're talking about cardiovascular issues. A stroke is when you get a big clot and lose a specific part of the brain. Lots of little ones, we used to say, can cause multi-infarct dementia. The word infarct means damage to something. You can infarct the heart, that's a heart attack. If you infarct the brain, that's a stroke. But it is a cerebrovascular accident. Cerebral means brain. Vascular means referring to blood flow. How we get to brain damage is a vascular issue. When we think about aging, there are many processes to aging, but there are three very, very specific ones that will affect all of us and affect our heart and our circulation. Everybody is going to have to acknowledge that these things always happen. And the good news is they are remarkably well understood, and we already have a huge number of tools to help us with it. So the three things. The first, chronic vascular inflammation. We're going to spend some time on that today, and the other ones we'll get to in episodes to come. Chronic vascular inflammation. What does that mean? Okay, I'm a mechanical guy. Our heart beats 100,000 times a day. 100,000 times a day. We have a pressure wave. That is a slapping pulse wave going down all of our arteries every day since before we're born, for crying out loud. What do we think happens? We damage the lining of our arteries, but we are awesome. We have a self-repairing mechanism. How the body repairs injury is called inflammation. So we have a relentless inflammation that is repairing our arteries all the time, and that's going to leave a mark. So we have chronic vascular inflammation. We're going to go back and explain that. The two other things that happen to all of us are pipelines, the arteries that carry blood all throughout our body. They will stiffen over time. That's not the same thing as the damage to the interior. These issues overlap, but the inflammation we can think of as rusting in a pipe, and the stiffening is a hardening of the pipe, if you will. So if we have a stiffer pipe, when we're young, our arteries can be very soft and flexible like rubber tubes, and we're older, they turn more like copper pipes. So they're a very different thing. Men and women, by the way, age very differently. We'll get to that. We say a stiffer pipe is going to be under higher pressure. Blood pressure, this is a useful thing to think about. That blood pressure is not a disease, it is a measurement. It is a measurement trying to tell us something about the strength and health and burdens on our heart, which is the pump and the pipes that it carries blood through. So our arteries are going to stiffen. Three things: chronic vascular inflammation, the wear and tear of time. Number two, the stiffening of the arteries and the raising of pressure. Number three, our heart runs by an electrical timer that tells us when to beat. So the electrical system, the battery of the heart, if you will, can wear out, even if the mechanics don't. So we all end up with differences in our heart's rhythm. We're going to spend in a whole episode at least on atrial fibrillation, which is a sustained irregular heartbeat. It matters a lot. But you know what? It's also not really a disease. It's more of a description of what happens to a heart as we get older. So you see, all of these things that we traditionally call diseases are not so much diseases at all. They are the natural processes of an aging heart and circulation. So I love to give a lecture to the medical students and out to the community. The lecture is titled, There's Almost no such thing as heart disease. So, if most of what we think of as cardiovascular disease is really the consequence of natural aging, it's just natural aging, we should know something about it and we should know how to manage it. And you might be thinking, oh, if there's chronic wear and tear and chronic stiffening and a change in the electrical system, maybe all my diet and exercise is not going to totally master all of that. Well, of course not. Obviously, the things we do helps, but that's not the only issue. So the first thing that's worth a lot of discussion is chronic vascular inflammation. So here's the mechanics. If you slapped your hand 100,000 times, by the end of the day, you would tear the skin off. So what would we do? The human body would actually form a clot. It would scab, it would scar. And as that scabbing and scarring forms, that's the healing process. Well, you know what? The same thing happens inside our blood vessels. So as the blood vessels have a natural inflammatory healing, we grow plaque. The process is called atherosclerosis, or plaque in our arteries. So plaque in our arteries, in the heart we call it coronary artery disease. Throughout the body we call it peripheral arterial disease, or PAD. In the brain we call it cerebro, meaning brain vascular disease. But it's all the same process. It's just the natural result of chronic inflammation, wear and tear, and we grow plaque. Well, if this is an all natural process, gee, what can we do about it? We can think about, well, what are the things that actually speed it up? Why would we age plaque faster? First of all, it's extremely important to understand that our genetics set the stage for how we're going to age in our arteries. Think about when we were like barely past Neanderthals, our caveman days. We didn't die from heart attacks. Heart attacks actually didn't become the major cause of death till after the invention of antibiotics. No, we died from trauma and bleeding. So we've had tens of thousands of years to genetically select to heal vascular injury well, to clot well. Remember, clotting and healing are part of the same process. Some people have a genetic advantage to grow plaque more aggressively and quicker. If that happens, well, congratulations. You are going to survive the first half of life to your 50s better than others. But you know what? Darwin doesn't seem to care much about us after we turn 50. So these things that work to our advantage in youth work against us as we get older. And so chronic vascular inflammation is going to have everybody grow plaque. Notice I'm just talking about growing plaque. I'm not talking about blockages. You do not need to block off an artery to create problems. As a matter of fact, most of our troubles do not come from a blocked artery. What? Okay, picture a pipe. Now imagine the pipe that's full of rust. Long, rusty pipe. It does not have to be blocked. Look at that pipe. Do you want to drink from it? No. So, particularly the arteries that bring blood up to the brain, if they are just lined with plaque, you could have extensive atherosclerosis, extensive plaque, rust lining that pipe. Little bitty clots love to form on the surface. It is the surface area that tends to drive little clot formation, little cracks in the plaque, little bitty clots, sometimes little bits of plaque, but let's just say gunk is going to flick off and get to the head, like drinking from a rusty pipe. You do not have to be blocked. I have a colleague I work with who's still wrapping his mind around the fact, and I'll tell him one of our patients has arteries with extensive plaque, but there's no blockage. And he just could not wrap his brain around how can you have extensive plaque without a blockage? And the answer is you just have gunk in your pipe. The flow is okay. Symptoms can be driven by flow. If you don't have enough blood flow, like to your heart, you can get chest pain, blah, blah, blah. But what gets us in trouble is the plaque-lined vessel that likes to form clots. And in the brain, little bitty clots showering up in the head can cause little bitty brain injuries. That is one of the major pathways to vascular dementia. The constant showering of microclots, or with the smaller blood vessels, little clots in the little bitty blood vessels downstream. So we need to keep the arteries healthy. Keep in mind that I just said it's the lining of the artery with plaque, not the blockages that causes trouble. And this is where it can be hard to know just how much plaque you have unless you look. Also, notice I said that a blockage might give you symptoms, but the lining is what gives you the clot and the plaque and gunks up your brain or can also injure your heart or whatnot. So there's no need to have symptoms before you have brain injury. Dementia doesn't cause pain. Dementia may not make you faint. And a very important thing, particularly when we think about blood flow to the brain and trying to prevent a stroke, prevent, not just avoid, but prevent a stroke, to understand that symptoms have no prediction to risk. It's not really about risk. It's about time, because things are going to change. Lots of good news, because this process of atherosclerosis, meaning the age-driven plaque growth, yeah, we got that biology down. We're really good at that. We can polish these pipes, keep them smooth, and keep little clots from gumming up the brain. Okay, plaque growth. We start off with our genetics. Sorry, we can't seem to change our genetics. If you want to get mad about your genetics, blame your mom and dad, but hey, where's that going to get us? They blame us for most things anyway. The things that we used to call, quote, risk factors of, quote, heart disease. What? What is a risk factor of heart disease? Well, what type of heart disease? 100 years ago, heart disease was rheumatic fever. We didn't have antibiotics. We didn't have penicillin. So if you got a strep throat, the infection chewed up your heart. But ever since the invention of penicillin, you don't see people with rheumatic fever. So we don't, well, I mean, you can, but that's not the number one driver of heart disease. So in the latter part of the 20th century, quote, heart disease was really talking about atherosclerosis, plaque. Because now that we had antibiotics, people didn't die of pneumonia, so you live long enough for the plaque to become a problem. And we realized that certain people were getting their plaque a lot earlier. And so we said, what are the risk factors? Number one, age. Well, that's absurd. Age is just the passing of a clock. And it's important to understand, as mentioned, we will all get older. Time is always going to move forward. Diabetes. Diabetes matters a lot. I'll get back to that. And then we talked about cholesterol, which was an enormous distraction of the 1900s. And pressure. Well, high blood pressure is actually its own issue and has a more limited role in the development of plaque. We'll get to pressure. If your pressure is too high and you ignore it, give it a couple of years or a decade, and you'll just beat up your heart. And that causes all sorts of trouble. But that's not the same thing as inciting plaque growth. It matters, but the atherosclerosis, again, is the genetics, the time, and the inflammation. And so the things we used to say are the, quote, risk factors of atherosclerotic plaque disease are really the accelerants of vascular aging. How do we age faster? Okay, this is where we have our first step of things that we can manage. So let's just acknowledge age is age, and we go through time, and you're going to have cumulative inflammation. So we can stop whinging about age and just accept it. Diabetes, smoking. Okay, smoking is the second worst thing you can do. We know not to smoke. Really? Do I need to tell you that? We got it. Don't smoke. Actually, the only thing worse than smoking on arteries, other than diabetes, is vaping. If you vape, you put nicotine, which is really toxic to blood vessels, into your system really quick. With only half-hearted dark humor, I tell my young patients, if you're vaping, smoke. I realize the vape folks wanted to try to wean people off smoking, and vaping has maybe some pulmonary advantage, but from a vascular standpoint, it's terrible. So if you're a teenager and you got to choke down smoke, that's a lot harder than having this wonderful vape delivery system. And the nicotine and all the things in nicotine are real irritants to blood vessels. So if you're an irritant to a blood vessel, what happens? You incite vascular inflammation, and you're going to age arteries a lot faster. So don't smoke, don't vape. We got that. But what's actually harder on arteries? The answer is diabetes. What the heck is diabetes? We talk about diabetes all the time. Diabetes, to a non-endocrinologist, to just a real doctor practicing real medicine, diabetes is about genetic metabolic mismatching. Huh? What I mean is if we eat something that we're not genetically well prepared to metabolize, we're going to start storing that. Now, the biology gets really complicated, and I hope to have some real diabetologists talk on our program to help us understand that, because we're really good at ways to help with diabetes. But on a vascular level, if we are not able to metabolize something we eat, our sugar levels go up. This is adult diabetes, not the childhood diabetes or juvenile diabetes, but run-of-the-mill adult diabetes, type 2 diabetes is what we call it. Our sugar levels rise, and our insulin levels have to rise. Insulin is our hormone necessary to metabolize sugar. And to a vascular doctor, like me, the higher sugar and higher insulin are real irritants to arteries. And I'm sure there's a vascular biologist out there rolling their eyes going, my goodness, it's way more complicated than that. But you know what? In the real world, it is sufficient to understand that if we run higher sugars and higher insulin, our arteries aren't going to like it, and they're going to age faster, sometimes a lot faster. What does that mean? We grow plaque a lot faster. So you can go from having minimal plaque to just horribly ragged-looking arteries, not necessarily blocked, but you can have rough plaque growing inside arteries fairly quickly if we have elevated sugars, if we have diabetes. And that rough artery, as it's growing, tends to be much less stable, meaning it likes to crack and it likes to clot. And if those clots block off the artery entirely, or in the brain, if they flake off into the brain and jam up the brain, you will have brain damage. Big clots will cause strokes, and clots in the hearts are heart attacks. So the number one thing that accelerates vascular aging is diabetes. We all kind of have a sense that diet and exercise matter. Exercise is just good for everything. We'll let that pass for a moment. We know that exercise is good. I often wonder why we still study exercise. There's never been a negative study. It's always good, so just exercise. We will talk more about details on exercise at some point. Diet matters. But remember, we said this is a genetic metabolic mismatching. Huh? We're not all the same. Newsflash. This is a challenge we have with how medicine is presented. We seem to have this relentless notion that we're all alike and one diet is the right diet. Do this. Why are we all alike? We're not. And different diets work differently for different people. So we kind of run into a certain folly when we assume that there's one size fits all. I remember in med school, again, this was back in the 1900s, a very well intentioned endocrinologist was talking about metabolism of food. And he said, look, you can't eat white rice, you will get diabetes because we can't metabolize it. I'm thinking, who is this we? I'm sorry, me and 2 billion of my friends and families in East Asia eat nothing but white rice. And you know what? They don't get diabetes. So maybe you Northwestern Europeans don't do so well with white rice, but that doesn't mean everybody has the same genetics. In Washington, D.C., we have a remarkable international community. People come from all over the world, the diplomatic corps and whatnot. And we see a lot of these folks as patients. And I find always amazing, some of them will come here and start to put on an enormous amount of weight fairly quickly and their blood sugar numbers get terrible. They're eating things that they've never seen before, and their body has no way of metabolizing it, and they get diabetes. So there is a lot to the genetics of metabolism and what we call endocrinology, which is the whole field within medicine of understanding how our hormones, how our metabolism, how these things work for all of our body function. If we're talking about dementia and we're talking about preventing vascular dementia, one of the things we really need to do is have best possible blood flow. That means we don't want plaque in our arteries. We need to understand that we are genetically programmed to grow plaque because that's a healing process. And that over time, there's relentless wear and tear, so we're going to grow plaque. Next step, what speeds it up? The answer is diabetes. That's the first thing. This is where your diet comes in. So you need to understand what diet works for you. And you know what? If you don't have diabetes or the pre-diabetic or metabolic syndrome, fine. I'm not going to pick on you about your diet. Some people do well with plant-based diets. That's not true of everybody. Some people do well with the higher meat, low-carb diet. That's not true for everybody. Mediterraneans, by and large, do great with a Mediterranean diet, but that cannot be fully extended to everybody. So you need to understand what diet works for you. You're going to have to work with your doctor, look at your blood tests, and understand your metabolism. And to step back and say, why are we doing this? Why are we treating our tendency to diabetes and treating our metabolism? And the answer is nothing is more irritating to your arteries than that. So you manage that, you've gone a long way to improving the health of your arteries. To prevent vascular plaque buildup and the trouble with blood flow from that, number one, understand your metabolism and don't have diabetes. Number two, don't smoke or vape. Mention that. That's easy to say. Don't have to go beyond that. Well, what are the other risk factors? Have you noticed I have not yet used the word cholesterol? I said cholesterol. Well, maybe I did. Cholesterol was the great distraction in the 1900s. Why? We didn't even know what a heart attack was until the mid-1980s. We used to think a heart attack was damage to the heart from spasming blood vessels. It's not. It's damaging to the heart from blood clots. Blood clots forming on arteries that had even modest amounts of plaque. And you look at the plaque under a microscope, there's cholesterol there. And when you look at people's histories, people with higher cholesterols more readily had heart attacks. Fine. Cholesterol is not one molecule. There are dozens of different cholesterol types of molecules, and cholesterol is an essential part of the human body. All mammals, really. A lot of our brain is made out of cholesterol. The nervous system depends on cholesterol. Our hormones, I mean, it's everywhere. So it's not an evil thing. It's part of who we are. Guess what? It's some of the cholesterol molecules are really irritating to blood vessels and will really promote vascular healing. Oh, wait, vascular healing, that's inflammation. That means plaque growth. Yep. So there are some forms of cholesterol that are more likely to drive us to grow plaque, make plaque growth faster. Some cholesterol molecules are, for lack of a better word, the fuel of the inflammatory system. But you see, cholesterol is an animal molecule. There are no cholesterol molecules in plants. And you can eat all the plants you want. Our body disassembles everything we eat and puts it back together. So a plant-based diet may be really good for your metabolism, but it doesn't mean you're exempt from vascular aging. There was one study that actually suggested vegetarians had higher stroke rates, and that probably is because their numbers may look a little better, and they did not think it was necessary to do anything to prevent vascular plaque growth. So I'm really winding around to the fact that we actually know how to prevent plaque growth, and we can do it, but we can't do it just with our personal efforts. So we need to look at our cholesterol, but we do not treat cholesterol for the sake of the number. The goal in life is not to die with pretty numbers. The goal in life, at least one of them, is to live long and live well, to have good blood flow, to not have brain injury, to not have dementia, to not become dependent upon our children to take care of us because we had so many strokes we can't function on our own. And so you need to have good vascular health. So we do not want to have undue vascular aging. So we don't want to feed it. You don't feed plaque growth largely with diabetes and smoking, and we are mindful of cholesterol, but by itself, that's not the most important thing. Blood pressure, it's its whole own topic. And again, it's not the main driver of plaque growth. So we'll save blood pressure for the next topic. So everybody grows plaque. Fine. Don't feed it. And you know what? Now you have to ask, is it time to stop it? What? Yep, stop it. Can we stop vascular aging? Can we stop the centerpiece of aging? Do we have an anti-aging pill? The answer is yes, we do. Yes, we do. And it's been around for a while. And some people have really embraced it and others less so. Statins. Statins are vascular medications. Statins prevent vascular inflammation. Statins inhibit the mechanism of plaque growth. They also lower cholesterol, but that's almost incidental, except it really does relate to the inflammatory process. In the real world, real doctors practicing real medicine, we often talk about cholesterol because people want us to, and it's easier to focus on. What's my number? Everyone wants a report card. What's my number? I want to know what's your plaque burden. How much plaque do you have? How much rust in your pipe do you have? And did I help you stop that from progressing and reverse it if I can? How do you stop plaque growth? You stop it with a statin. Well, there are a lot of statins. They all work. And different statins work for different people. They have different degrees of their anti-inflammatory effect. So you can look up the Jupiter trial. Came out a couple years back. It was a marvelous study. One of the first time we looked a lot at women over the age of 50, who had normal cholesterol. Let's be clear on this. Normal cholesterol. Yet they had markers of vascular inflammation or evidence of vascular inflammation. And so we gave them a statin, particularly rosuvastatin. Now keep in mind, all the statins are generic. I get my statin for free from my insurance company. Here, take it. I mean, they'd rather give me a free statin than have me have a stroke, for crying out loud. For free. So it's not like the big pharma is trying to sell us on statins. They don't care. They give it away, literally. Zero copay on mine. Now, I don't know if every insurance company is like that, but at least mine does. Point about that trial is normal cholesterol. We gave women and men, but a lot of women, a statin, and the study had to be stopped early because of the overwhelming efficacy. There was a sharp drop in what? Strokes, brain damage. So we are improving vascular health. So quite likely the single most powerful tool in the prevention of vascular dementia are statins because they arrest vascular aging and they help promote reliable blood flow throughout every organ in the body, particularly the brain. And so, well, guess what? If you prevent vascular aging in one place, you largely prevent it everywhere, although we have to be mindful of just how much plaque we may have developed before we started. But you start someone on a statin, my goodness, the clock stops and their arteries just stop aging. It's just amazing. And we look for this. We can look at your plaque burden. So, well, if statins are so wonderful, why don't everybody take them? Maybe everybody should. Maybe. But again, we're all different. And it is true that some people age much more slowly. Some people don't have the premetabolic syndrome nearly as quickly in life, and they don't have vascular aging, and you could argue they don't need a statin. It is also true that there are a lot of people who don't tolerate statins, but it's worth mentioning that. There's a lot of perceptions. There are those who have used the term an internet-driven conspiracy of statin denial. So what I like to point out is that statins have something we call a nocebo effect. What? Nocebo. A lot of us have heard of placebos. A placebo, as you may know, is if you feel bad and I give you a pill with nothing in it, you'll feel better. That's the placebo effect. It's extremely powerful. The placebo effect is extremely powerful. It can really help people feel better. And there's a lot to that. If I think I'm going to get better, that helps me get better. And there's all sorts of stuff about how the brain can influence all aspects of our body. So I believe in the placebo very strongly. I even when you tell people this is a placebo, it's not going to do anything, but you'll feel better. We can do that. Well, what's the opposite of a placebo? The opposite of placebo is if you believe something is going to have give you a side effect. If you believe that, it's going to give you the side effect. That's a nocebo. I remember in med school, we talked about the little kids who had to get chemotherapy and they knew what was coming. They'd start throwing up before they even got their chemo. Now, again, I don't do pediatrics and I don't give anyone chemotherapy, and things are way better. So I don't want you to think that every kid who gets chemo is going to be sick. But the point is if you knew something was coming that was going to make you sick, you got sick before you even got the medication. Statins have an extraordinarily powerful nocebo effect. People think they're going to give you aches and pains. In fact, the nocebo effect is so strong, it will affect people before they even take the statins. What? I love it. People come to me all the time. Oh, I can't take a statin. I have aches and pains. It's like, have you taken it yet? No. Oh, so it's already giving you aches and pains and you haven't started it yet. I find that extraordinary. Now, if you don't want to take the statin, you don't want to take the statin. But my job as your real doctor is to give you my best advice. My best advice is, look, I don't want you to have a stroke. I really hate that. That's my bias. I really hate strokes. That's why we do a lot of these talks. I don't like people having brain injury, especially if I knew I could have helped you prevent that. Prevent is an active verb. It's not just about passively saying, oh, I don't want to have the risk for this. No, I'm going to prevent it. I'm going to prevent a vascular brain injury. And if I know I've seen your arteries and I've seen the plaque in your arteries, you can see it with ultrasound. I just look at your artery and I know you're just waiting to have a vascular brain injury, or maybe you already have had a vascular brain injury. Maybe you've already had mini strokes. Maybe someone did an MRI and said, oh, look, you have these small strokes. And if I can't convince you on how to do something to prevent further brain injury, I really feel like it's my fault. If I hear somebody's had a stroke, I quietly think in my mind, who allowed that to happen? Why couldn't we have prevented that? Yes, strokes are brain injuries, and cumulative brain injuries, of course, lead to a brain that doesn't work. So that is vascular dementia. No matter what else is going on, we don't want to have vascular dementia, especially if we should prevent it. So if you're over 50, you probably have something that hurts. We have aches and pains. I've never bothered actually surveying people in a formal study to say how many 50-plus-year-olds have aches and pains, but by golly, I can't imagine that anybody doesn't have something that hurts. So if you already have something that hurts, why on earth is the statin? There's not a mechanism for it. Now, we've actually done a couple of really big studies where you take big groups of people and you do what's called the randomized double-blind crossover. In other words, you take a placebo or you take a statin and you switch back and forth. And we can't find any difference in the aches and pains between the placebos and the statins, nor do we have a mechanism for it. That being said, in the real world, I fully understand that not everybody can take every pill the way we think they should or could be able to do it. And so, if you have plaque, we need to stop it. There's more than one statin. There's rosuvastatin, atorvastatin, pravastatin, simvastatin, pitavastatin. There's a bunches of them. And you know what? They're not all the same. There's some subtle differences. You can work with your doctor. Maybe you can find one that works. And remember, we take statins not simply to treat cholesterol. Actually, I almost don't care about your cholesterol. We take them because statins stabilize plaque. They prevent plaque growth. They reduce your plaque burden. And most importantly, every time we stop studying them for efficacy. Why? Because they so profoundly prevent heart damage, heart attacks, and more importantly, strokes, brain damage. So we want to prevent brain damage. You need to stop vascular aging. Okay, there are some people who really, really, really can't take a statin and they give it the good college try and try different pills. Fine. We do have other choices. There's a wonderful study that came out a year or two ago looking at something called bempedoic acid in people who are intolerant to statins. Not quite as powerful as a statin, but a pretty darn nice alternative. There's also a couple of injectables. There are shots you can get, these things called PCSK9 inhibitors. There's a shot you can get that you only have to take twice a year that has this remarkable mechanism, again, not just to lower cholesterol, but to change the mechanism by which we're growing plaque. And we you can't currently get approval from the FDA for any new medication unless you can demonstrate efficacy. And the efficacy isn't just fixing your numbers. You had to show that we reduced events, meaning we're preventing brain damage. We're preventing strokes with the medicines that we use. So statins are free, by and large, and if you can take them, great. There have been drives to make them over the counter, but guys like me kind of resist that. Why? We're a little bit of a control freak. We want to have the right dose and the right medication and the right person at the right time. Because we use low dose therapy in people without a high plaque burden, or for the early prevention of somebody before they've grown plaque. And we use high dose therapy for people who have a high plaque burden. You have a lot of plaque in a lot of arteries, or they've had prior events, a prior heart attack or a prior stroke. So again, it's not one size fits all. I've mentioned plaque burden. Plaque burden is a question of how much plaque do we have and how do we know? The easiest way is to just look. There are a couple ways you can look. One test that is very commonly done and commonly recommended is something called a CT coronary calcium scan. And again, I'm interested in the brain, but the process is everywhere. If you get an x-ray anywhere and it shows that you have calcified arteries, great. Congratulations, you're old enough to have vascular aging. What do you do with that information? You talk to your doctor and say, am I on enough vascular medication? Should I be on a statin if I'm not? Do I need to be on a specific stroke prevention medication? We'll get to that. And so those tests are not to tell you that you have a problem. It's just to acknowledge that you have vascular aging. An awesome test is our vascular ultrasounds. Now, what we do in our practice and what a lot of people are beginning to do is to ultrasound the carotid arteries. These are the key arteries bringing blood up to the brain. You have two carotids, one on the left, one on the right, and they are bringing blood from the heart straight up into the brain. They're the highest flow parts of the circulation because the brain is the heart's priority. And so there's a lot of turbulence when they have their first split. The carotids fork, they go into the brain and then out to the rest of the skull and face. That's one of the earliest places we see plaque growth. And it's arguably one of the most important places to know if you have plaque growth. And it's not about blockage. It's about, oh, you have a little bit of plaque. If you can go to the Foxall Foundation website. I'll see if I can post some pictures of what arteries look like. It's amazing. You can have just lines, a row of plaque, and sometimes it's like cloud watching. What does this plaque look like? Oh, this one looks like a shark. That one looks like Pac-Man. This looks like a boat. I mean, we have rough edges. It's like coral growing in our arteries. Yet it's not blocking flow. So you can get an ultrasound, that's great, and you can see your plaque. Sometimes we even see clot flicking around on the plaque. And that's obviously not a good thing, but we can deal with that. but it's not blocked. So if you do get an ultrasound, you would want to talk to your doctor about what do the arteries look like? Did I have any plaque, and what was the characteristic of the plaque? Because unfortunately, a lot of times we get a report back from a hospital based on the 1900s. We used a scale, and it would say 0 to 49% blocked, normal. What? My whole artery could be lined and 49% of it full of plaque, and you're telling me that's normal? It's normal because it doesn't limit flow, so you're not going to get any symptoms from that until something flicks off. It's normal because you would never need to have surgery for that. We don't need to open it up or operate on it. And in the 1900s, the only thing we could do for an artery was operate on it. And now we understand this is a medical issue. We can use medications to keep the blood flowing. Another future episode, we'll talk all about different tests we get to screen for all sorts of things. But for now, I want to let it go there to say step one in understanding dementia is to say, I want my brain to work as best as possible. For my brain to work as best as possible, it needs to have best possible blood flow. I need to optimize circulation. I know that if I have inadequate or impaired or interrupted blood flow to my brain will suffer. And I know that over time, things change. There are processes that I have the opportunity to manage. The first of those processes is simple vascular inflammation, which is universal. We all have it. I know that I don't want to feed it with diabetes, so I'll be mindful of my blood tests, work with my doctor, ponder what diet works for my metabolism, and make sure I stay as fit as I can. I know that tobacco and nicotine products accelerate vascular aging. I know that cholesterol is not the whole story. It's a contributor, but having a good cholesterol is certainly not sufficient. I know that I want to, at some point, arrest plaque growth. I can have an anti-aging pill and protect my brain, and I can do that with a statin. And there are alternatives if I really can't take a statin. But before I assume I can't take a statin, I probably should try. So, yes, there's more to circulation. I mentioned that there are other parts of vascular aging and cardiac aging and things that would limit or impair blood flow to the brain. So the next episode or two, we'll explore those. So for now, thank you for listening. Again, I'm Josh Yamamoto, a real doctor practicing real medicine, and I hope you enjoyed this broadcast.